Now, to start off, I recommend hiring one CRNA per track to alleviate anesthesiologist bottlenecks and assigning PAs to assist surgeons with non-critical tasks. Pooling OR and anesthesiologist resources is a low-cost way to improve flow times and process efficiencies. BMI-based scheduling will reduce flow of variability, and standardizing pre-op and sedation workflows will further minimize this variability. These changes aim to increase throughput to 7 surgeries per day per track and reduce average patient flow times to 4 hours or less, with a 95% confidence interval of 3.8 to 4.2 hours. Now, Hipkins currently operates with 2 tracks, tracks A and B, with 2 ORs in each track. The workflow consists of patients arriving every 90 minutes starting at 7:30 a.m. and they process through registration, pre-op sedation, surgery, OR cleaning, and recovery. Now, the resources can be categorized between shared resources such as registrars and EVS staff that handle patient intake and OR cleaning across both tracks, and dedicated resources such as surgeons, anesthesiologists, and ORs that are fixed to each track. Now, this rigidity leads to cascading delays, particularly for late-day patients, and constrains throughputs to below optimal levels. Now, in this base case, we can observe 3 main challenges. First, with throughput, the hospital performs about 4 surgeries per track per day, which is very much below the private practice benchmark of about 8 surgeries per day, making this hospital very uncompetitive compared to these private practices. Now, with flow time, while early day patients experience flow times of 3 to 3.5 hours, late day patients can experience flow times even exceeding 5 to 5.5 hours. And now with resource utilization, anesthesiologists tend to be very overutilized at a utilization of 97%, making them the primary bottleneck. ORs are not close behind with a 90% utilization with little flexibility, and surgeons have a little bit more flexibility with the 77% utilization. So they are actually presently underutilized but cannot increase productivity without resolving the upstream constraints. Now let's first talk about tackling the bottlenecks. I recommend 2 staffing changes. Now first, we've already identified that anesthesiologists are the primary bottleneck, with ORs being the secondary bottleneck. Now I suggest adding 1 CRNA, which can handle routine sedation and end of surgery tasks, reducing anesthesiologist utilizations to about 84 to 90%. Now this adjustment increases surgeries to 5 to 6 tracks per track per day and improves transitions, but late day delays persist without additional changes. Now, I also recommend that we assign PAs, as they can assist surgeons with non-critical tasks like wound closures, reducing surgeon utilization to about 61 to 72%. Now, this also frees up surgeons to focus on critical surgeries and enhances overall efficiency. Now, with these adjustments come additional costs, so the revenue potential from increased throughput offset them. However, staffing changes alone cannot fully resolve the challenges. Now, since staffing changes will not solely solve all of our problems, we also looked at pooling resources, which can be a low-cost strategy, where ORs and anesthesiologists previously dedicated to tracks A and B were centralized into shared pools. While this allowed surgeries to take place in any of the 4 ORs and enabled anesthesiologists to respond flexibly to demand, the results showed no immediate improvement in throughput, which remained at about 4 surgeries per track per day. Resource utilization also remained constant for ORs, anesthesiologists, and surgeons. And flow times still average around 200 minutes, so 3 to 3.5 hours. And late day patients still face longer wait times, highlighting ongoing scheduling and fairness challenges. So now overall, pooling alone did not resolve bottlenecks or improve flow times, but it could be impactful if combined with other adjustments, such as adding CRNAs or PAs as previously discussed, or implementing dynamic scheduling models to prioritize surgeries based on duration or complexity. Now, it's also important to try to manage and lower variability. In terms of arrival time and variability, this can be very hard to manage due to uncontrollable factors that might impact when people do in fact arrive. But in terms of process availability, I really saw that due to the differences between lower BMI and higher BMI patients, that perhaps by segmenting patients by BMI into 2 groups, this could be a successful strategy. Now I found that segmenting, say, lower BMI patients into track A and higher BMI patients into track B, lower BMI patients actually reduced surgery times, whereas higher BMI patients actually saw higher surgery times compared to lower BMI patients, and they actually increased their variability. So thus, track A and lower BMI patients have some gains due to this change, but track B and higher BMI patients experiences higher delays, which could offset these improvements. Thus, there needs to be additional steps taken in order to help reduce variability, such as standardizing pre-op and sedation workflows, which can reduce variability in these steps. And also, scheduling longer surgeries earlier in the day can prevent log jams and balance throughput across both tracks. And let's not forget that psychology matters, and it's important to improve the patient experience as well. First, there needs to be enhanced communication, such as real-time updates through digital displays, text alerts, or staff interactions that help manage patient expectations. Transparency really helps build trust and reduces uncertainties for patients and families. I also recommend waiting time enhancements, such as adding amenities like comfortable seating, refreshments, and Wi-Fi that can make waiting more bearable, and adding calming elements such as soft lighting, plants, or quiet zones to help reduce stress levels. Now, these psychological improvements complement operational changes by improving satisfaction and aligning with the hospital's patient-centered values. Now, this leads to my strategic recommendations, which are first to hire a CRNA to reduce anesthesiologists' workload, thereby lowering their utilization to 84 to 90%, and also to assign PAs to assist surgeons, thereby reducing their utilization and also enabling them to focus on more critical tasks. Now, in terms of scheduling optimization, as we've just previously discussed, I recommend implementing a BMI-based track strategy, but it is important to make sure and monitor that track B is not being disproportionately impacted by this change. Now, it's also important there then to standardize pre-op and sedation workflows in order to further lower variability, and also schedule longer surgeries earlier to prevent delays for subsequent cases. Now, in terms of resource pooling, I suggest that we centralize ORs and anesthesiologists to improve flexibility and scheduling efficiency. And in terms of psychological improvements, I suggest enhancing patient communication to set expectations about potential delays and also to improve waiting areas and amenities to reduce stress for patients and families. Now, it is also important to make sure that these changes align with Hopkins' DEI principles. Now, in terms of equity, standardizing workflows ensures consistent care delivery, minimizing disparities due to variability in staff or resources. Now, ideally, recommending BMI-based tracks does not discriminate based on weight, but allows for specialized treatment depending on a person's BMI, thereby improving service quality and flow time for patients across all BMI ranges. However, as our results show, higher BMI patients fared worse than lower BMI patients in our simulations. But combined with other recommendations I'm making, this could thwart the negative impacts that higher BMI patients were receiving. Thus, it's important for Hopkins to monitor that higher BMI patients are not being disproportionately affected. Now, in terms of inclusion, cross-training and pooling encourages collaboration amongst diverse teams, thereby ensuring that everyone contributes to patient care improvements. And in terms of diversity, optimize processes, respect cultural and individual differences, accommodating unique patient needs while enhancing satisfaction. Thus, to transform surgical operations at Hopkins Hospital, I recommend hiring one CRNA per track and assigning PAs to support surgeons with less critical tasks in the OR and/or outside the OR. This will help increase efficiencies and surgeon productivity in the OR and other critical areas. Moreover, implementing BMI-based scheduling and pooling OR resources will help streamline process flows and provide more resource flexibility. On this note, standardizing pre-op and sedation workflows will help to further minimize variability, thereby streamlining operations further. Through implementing these changes, Hopkins Hospital will increase its throughput to 7 surgeries per day per track and also reduce patient flow time to 4 hours or so. Together, these improvements will optimize patient flow, enhance patient satisfaction, improve the overall patient experience, and maintain the hospital's commitment to equitable and quality care for all incoming patients. This will help the hospital compete with other private for-profit hospitals in the area, and thus better position itself for long-term sustainability and profitability.